Good evening, dear friends of Indian Orthodontic Society, and it's my pride and pleasure to welcome you all for Sunday's program and the highly expected even iOS masterclass. And today we have a wonderful speaker, Dr. Madhur Upadhyay, all the way from US, connected to us virtually. And before we start with the program, I'll start with the invocation. So we have Dr. Vaibhava here, a postgraduate student from Sri Balaji Dental College and a student member of Indian Orthodontic Society. Dr. Vaibhava, can you start with the prayer?
Yes, sir. Shri Ganesha Sharanam, Shri Ganesha Sharanam Gajanana, Shri Ganesha Sharanam Gajanana Devanunu, Shri Ganesha Sharanam Sharanam Sharanam.
Thank you, Vaibhava. That's so enlightening for the evening. And let me again welcome you all, respected seniors, teachers, fellow colleagues, and members of Indian Orthodontic Society. Let me first welcome our president, Dr. Silju Matthew here, and our charismatic secretary, Madam, Dr. Sridevi Padmanabhan is also here, and the star speaker for the day, Dr. Madhur Upadhyay, all the way from US is here with us, and the moderator for the program, our own dear Dr. Ritu Dugal, Madam. Welcome you, ma'am, and glad to have you as the moderator for today's program. And I request Dr. Silju Matthew to unveil the program and share his thoughts.
Thank you, Dr. Kanan. Greetings to one and all. Madam Secretary, the Vice President, President-elect, the Principal Office Bearers, the distinguished EC members, the illustrious speaker for the day, Dr. Madhur Upadhyay, learned moderator, Dr. Ritu Mughal, Madam, past office bearers, senior panelists, senior members, and dear friends. A warm welcome to one and all to the 7th lecture of the Ortho Trend Masterclass 2021. No matter how skilled you are or clinically experienced you are, it is essential to have a sound understanding of the fundamentals of biomechanics. Contemporary orthodontics always tests your biomechanical acumen in challenging cases. Even the new age clear aligners requires a sound knowledge of biomechanics to plan your treatment of attachments for planned tooth movement. Therefore, mastering these concepts are essential for better results and sustaining them. Today, to enlighten us on the topic, we are privileged to have someone who is the master in the field and who will enlighten us on biomechanics for the modern era. I welcome Dr. Madhur Upadhyay from the Center of Orthodontic Care, University of Connecticut Health, USA, who will be taking us through this intriguing world of biomechanics. My special thanks to Dr. Ritu Dugal, Madam, for consenting to be the moderator, a profound academician, researcher par excellence, and distinguished scholar. I also thank the organizers of the Academic Council members, Dr. Puneet Batra, who's the chair, and of course, our charming, untiring, and ever-smiling Madam Secretary. And finally, the MC of the day, the charismatic, creative genius, a fitness guru, and colorful, though today is in white, Dr. Kanan Sabapathy. Wishing you all a great insight and engrossing roller coaster ride of blending biology and biomechanics to unravel the challenges of present day orthodontics. Thank you. Jai Us, Jai Hind. Please stay safe and take care. Over to you, Dr. Kannan.
Thank you, President. That was a wonderful welcome message, and it's your positivity which has been carrying iOS to at global level, and been you made the iOS flag, play and to glory at the global scale. Thank you, the President, and thank you, Dr. Madhur Upadhyay, and you are going to enlighten us today. We are eagerly expecting for your lecture. The best way to honor you would be like our own valued member and our own secretary introducing you. So, Dr. Sridevi ma'am, please, we request you to introduce Dr. Madhur Upadhyay.
Thank you, Dr. Kannan. A very good evening to all of you. President, Indian Orthodontic Society, Dr. Kannan, who's the MC for the day, Dr. Madhur Upadhyay, Dr. Ritu Dugal ma'am, who is coordinating the session, Dr. Puneet Batra, other EC members, and of course, distinguished iOS members who have joined us today. Dr. Madhur Upadhyay is actually a household name, and he really doesn't require any introduction. I think he spoke last year also when this pandemic started, but obviously Dil Mange More. So we are going to listen to him once more, talking on biomechanics for the modern age. Dr. Madhur is the Associate Clinical Professor and Director, Center for Orthodontic Care at the University of Connecticut Health. He is also the Director of the Orthodontic Fellowship Program. He is a diplomate of the ABO, and he also holds an active membership of the Angle Society. We all know that his research interests includes biomechanics of tooth movement, and he also has interest in skeletal anchorage. He's published extensively. He has more than 100 scientific papers, book chapters, and abstracts in national and international journals, and has made numerous scientific presentations at various international meetings throughout the world. He has also been the recipient of various foundation and industrial grants. He serves on the board of various orthodontic journals like the AJODO, the Angle Orthodontist, and the European Journal of Orthodontics. He also maintains an intramural practice at UConn Health, and he still finds time to pursue other interests. He loves to play tennis. He also has a keen interest in physical sciences, especially astronomy. So we are very, very happy to welcome this multifaceted individual today, and we are hoping to listen to you. Welcome, Dr. Madhur Upadhyay. Over to you, Dr. Kannan.
Yeah. And once the pandemic jolted the entire world, it's like iOS under the great leadership of Dr. Silvio Matthew and Dr. Sridevi Padmanabhan evolved to connect virtually and actually get super active with all the activities of Indian Orthodontic Society. And Masterclass is one such program which became a big hit and which has been followed globally, not just by members of Indian Orthodontic Society, and a lot of members from global orthodontic societies are following Masterclass. And we are glad to have Dr. Madhur Upadhyay today as our speaker. And all credits goes to the Academic Council for basically we are an academic society. So the Academic Council headed by Dr. Puneet Batra had been performing phenomenally. And thanks to Dr. Puneet Batra for making all the successful the programs all of grand glory. And here, Dr. Puneet Batra, please, today I request you to introduce Dr. Ritu Dugal, our moderator for the evening.
Good evening, everyone. Thank you, Dr. Kannan. Thank you so much for being, the bright, shining star of Indian Orthodontic Society. Well, at the onset, I want to thank the President, Dr. Silju Matthew, the cornerstone of positivity in the society during these tough times. Dr. Sri Devi, Madam, belated happy birthday. You are, the powerhouse of energy. Dr. Sri Krishna Chalsani, my academic council, Ashish Garg, Dr. Ashish from Bhubaneswar, Dr. Pradeep Raghav, Dr. Padma Priya, Dr. Raj Ganesh Gautam. All of them have been a cornerstone and have helped me in setting up the academic calendar. And thank you, President Sir, for being so open and allowing us to function in this manner. We are really thankful, and I welcome now. Today's all these master classes have been lucky days for me. Why so? Because I have had the honor to introduce people who have influenced my life throughout these years. And the person who influenced my BDS and MDS life is no other than Professor Ritu Dugal. She was my BDS teacher in orthodontics, and she became my MDS teacher in orthodontics at AIMS. She is the chief of the Center of Dental Education and Research and professor and head division of orthodontics and dentofacial orthopedics at the prestigious All India Institute of Medical Sciences, New Delhi. She is also the director of WHO Clinical Coordinator on Oral Health Promotion and National Center of Excellence for Implementation of National Oral Health Program. She's been a guide and mentor to many postgraduates, including me, and has influenced the life of numerous research and PhD postdoc students. Under her guidance, more than 50 research projects, including basic sciences and clinical sciences, have been conducted. Her acumen in research and communication skills is par excellence. Her compassion for colleagues and her students is beyond greatness. She has over 80 publications in various national and international journals to her credit. With an academic career of over 30 years, she is known among her students for being compassionate and approachable. Having a special interest in non extraction treatment, functional jaw orthopedics, she strives for continuing to render excellent patient care and the highest quality of research at the esteemed center in years to come. So, it's a lucky day for me, ma'am, to introduce you. You have been the cornerstone of life of so many orthodontists. We are really privileged to have you today as a moderator for the day. Over to you, Dr. Kannan.
Thank you, Dr. Puneet, and congratulations again for all the successful masterclass program. And this program is going to be another feather on your cap, and we are so much proud of you. And yes, and with the formalities, let's start with the program. And already I see 316 participants. Wow, that's a beautiful number. It's a conference number, and yes, so many of the members eagerly awaiting for Dr. Madhu's lecture. And all of you keep your mics would be mute. I mean, would be muted by the secretary. And the panelists, I request you all to keep your mics muted. Once Dr. Madhur starts with his presentation. And if you have any questions, please type it in the chat box. So, and Dr. Ritu Dugal would, at the end of the program, would be discussing the questions and asking for answers from Dr. Madhur. So here, I pass it to Dr. Madhur. And yes, Dr. Madhur, please, I request you to start with your presentation.
Okay, I hope everyone can hear me and see my screen.
Yes, you're good to go.
Yes.
Okay, awesome. Thank you so much for the invitation, specifically Dr. Batra for getting in touch with me and pulling me into this. It's always a wonderful feeling to, always now and then get back to your roots and share some of the knowledge that I've acquired over the years and give it back to my community. I'd like to also thank Dr. Padmanabhan, who got in touch with me in time, and I could get the link to get into this meeting myself. So thank you for that. And thank you for the whole IONS panel for organizing this. So I would not like you guys to wait anymore, and I'll get on with it. Hopefully I can do some justice to this topic of aligners, which I'm sure all of us have been touched by it in some capacity or the other, and most of us are directly involved maybe in treating patients with this. So let me see what I can bring out. Hopefully it will be something that you can take home and improve your clinical practice and knowledge base on it. So for those who don't know me, I am Madhur Upadhyay, and I'm at UConn Health. For more information on me, feel comfortable to scan the QR code and read it, and you'll perhaps get to know a little bit more about me through that. So to me, knowledge is important. For all of us, knowledge is so critical. However, knowledge is good to know theoretically a lot about things, but experience is the key. When you start connecting those dots of knowledge, And suddenly that knowledge starts acquiring some kind of shape that can be utilized, channeled, and taken leverage from to improve your life, practice, and overall your well being. By experience, I do not mean that a clinician working in the clinics and seeing patients after patients. Well, that is one way of acquiring experience. But I think experience is an amalgamation of doing research or slash reading research, and uh, talking a lot about what you have acquired over the years. So it's a combination of clinical knowledge, it's a combination of research, and then finally, it boils down to you discussing all the acquired wisdom with your colleagues and friends, be it through teaching, discussions, meetings, etc. So I have been fortunate enough to gain now some experience in aligners over the years because I've been involved with it in various capacities. And that is why I would like to put out a particular disclaimer so that you can analyze what I'm saying based on my background. So I've been involved, and I've acquired various grants from Align Tech to do some research. The first grant happened almost now 9 to 10 years ago. Uh, Previously, I have been an active member on the Alliance, and by Align, I mean Invisalign. So I've been a member on the Research Award Committee, for which I was a paid member. So there's some financial angle to it. And I have been, of course, an active aligner provider and investor. So please take all the information that I have to share with you with a little grain of salt and keeping this um, in mind. So this is one of my first patients, perhaps, I think. Tough to recollect, but I believe it is because I pulled it out from an archive of my patients who I happened to treat with aligners. I was told at that point that these are good patients to start aligners with. We do not have a lot of malocclusion going on, and the case is supposedly straightforward. So this patient had the main issue of this midline diastema that you can see in the front. And she also had some basic generalized spacing, but as you can see, nothing serious going on except a slight broody tendency on that upper right premolar and, something else that you guys are, smart enough to pick up all the other things here. So the plan was pretty simple, close the gaps. She never wanted braces. She absolutely refused it. So of course, went to aligners. By aligners, I always would mean here Invisalign. So just put that in context. So we went ahead and we planned the treatment. And we went ahead and did the treatment. Spaces were closed. As you can see that the teeth are showing some kind of lateral open bite, a little bit of cross bite or edge to edge bite on the right side and even on the left side. There's almost like a general squeeze of the whole arch. So of course you went through refinement, did refinement number 1, we did refinement number 2. So multiple refinements, continued with the treatment and could achieve some kind of decent occlusion on the left and right side. Had to use a lot of attachments, as you can see. For settling, had to use some elastics, for some AP corrections on buttons. So a lot of things went into it because at that time, my goal was, I was trying to compare this with braces, right? So you're trying to finish the patient in that manner. And still there were some things that were not complete to my satisfaction. The diastema was still there. Too bad I couldn't finish the patient because the patient had to move and she was entering college, so she had to go to a different state. Uh, Perhaps she continued treatment here. But the bottom line is that this patient is like, an example to show my initial few steps into aligners. That initial introduction of similar patients showed me that my journey would be a bit long with aligners because I was nowhere close to getting the same kind of satisfaction that I was getting through braces. So this presentation would be like a synopsis of my 8 to 10 year journey now through aligners. And What I intend to do that, because time is of essence and all of us are busy, we don't have like a full day to spend on this. So I'll take you through this journey that I did. I tried to understand what the aligner business was. What was the whole point of doing this? How are the aligners trying to move teeth? Because they don't look like braces, not at all. So they are doing something else to move teeth. How are they treating different malocclusions? What are the basic biomechanical foundations of aligners? Because they got to be different at the face of it from braces. And try to then understand all this from a first principles objective. That is, try to analyze its performance and shortcomings. And because I knew there would be shortcomings, as I experienced in that one patient that I showed you and many more, so I had to find a way out of it. And so I got into it big time. I started writing grants. I started trying to review a lot of papers on it, do research, and same time treat patients. So number one, how big is now the aligner industry? Of course, when I started, it was very tiny, but at this point, the aligner industry comprises perhaps of more than 100 companies that I know of, that I've gathered through the literature. I'm sure there are many more that are unregistered and they are functioning. Specifically talking about Align Tech, which is the mother company for Invisalign, it's a more than $50 billion company at this point. At least the NASDAQ showed the same a few days ago. I don't know if the shares have fallen off or something, but it's greater than $50 billion. And it occupies about, I would say, 35% to 45% of the share of the aligner business. So the total market is close to $200 billion, which is huge in our profession. So that's the scope of it. And that showed me, or it still shows me, that this is something important to gain knowledge into, because it is growing at a very rapid pace. And so it's not a good idea to shy away from it or to throw darts at it and try to always find mistakes, but try to understand the mistakes and see if they can be improved, or our orthodontics can be smartly tailored around it. We got to be also careful that because so much money is being invested in this company, there'll be a lot of gurus, salesmen, proponents, propagators of this technology who will in some way or the other try to push these aligners to you. So it's very important to step back and try to analyze how they work on a first principle basis. So what are the tools of aligner mechanics? Now, I want to keep it simple and straightforward. So in this limited time, I'm not going to dive into the nitty-gritties or all the nooks and crannies about aligner mechanics. So broadly speaking, most of the aligner companies are approaching treatment with two approaches. The first approach on moving teeth that they adopt is called the shape molding effect. Many of us know what a shape molding effect is, because at some stage of our career, we have gone to our labs, taken an impression of a patient, cut the teeth out on the mold, and rearranged them in an aligned manner or in the manner we want, and done a suck down Essex retainer or any kind of plastic retainer on it. So basically, that retainer or that suck down Essex or aligner is forcing the teeth from a crowded position to an aligned position. So the whole shape of the aligner is pushing the teeth into its correct position. So this is known as the shape molding effect of moving teeth. That's I think, the primary mechanism till this date Invisalign follows. 80% of their movement is by the shape molding effect. The remaining 20%, you can say 19%, let's leave 1% out, but the remaining majority out of that, after 80%, happens by something called as attachments. Now, these attachments are basically blobs of composite on the tooth that are transferred by trays. You would notice that at least one surface of this attachment is flat, straight, and perpendicular to the tooth surface. This is very critical for the proper delivery of force, because it is this flat surface that takes up the force that is being applied by the aligners. Now, attachments is in certain situations a smart way of applying force, but in most, perhaps it is not. And that's why shape molding effect is the dominant way of moving teeth. And I'll show you why that is. So this is just one of my patients. Now, suppose I want to apply a lot of force on this premolar, just an example, to move it in a certain way. Now, either I can do by a shape molding effect or by using attachments. When I do a shape molding effect, maybe I'll distribute the force all over this surface. So for example, you're applying 200-gram force. You distribute it over the whole surface. So the stress absorbed by the tooth would be force by area, which will be 200 divided by the area of this tooth. Now let's assume this area is like what, 10 millimeters by 10 millimeters, so 100 millimeters square. So 200 by 100 gives you 2 gram-millimeter square of stress, which is great. How about if we try to do the same with the attachment? So if I apply 200-gram force on this attachment won't be more than 10 millimeters square in surface area, even maybe smaller, assuming that you're only applying force on this flat, straight surface. That gives you a stress of about 20 grams per millimeter square. So it's the stress received by the attachment is way higher than by the shape. And try to just remember this point that the stress received by the attachment would be way higher, because we'll see later why greater stress is really bad for aligner biomechanics. So just keep that fact in mind, that you want to not have a lot of force being created by attachments, but more by the shape molding effect. Okay, so once we know how aligners move teeth, let's look at how aligners are treating basic malocclusions. Now, most of this comes straight from the Invisalign and some other companies as to the little literature they have put out to show us that how they are trying to move teeth. So I'll just quickly review them malocclusion by malocclusion uh, to understand how they're moving teeth. I'll also add a little bit of my inputs that we have gathered through some systematic research. So let's look at deep bites. Okay. Deep bites are corrected by two basic mechanisms by aligners. Of course, with braces, we have like a ton of approaches to fix them, but aligners can only do it primarily by two ways. The first is, I like the name, that's why I stick to it. It's known as the watermelon seed effect. What it basically means is, like, if you take any seed, like an orange seed or even a watermelon seed, and try to squeeze it between two of your fingers, eventually it might slip out from one end. Okay, so the squeezing force gets transmitted straight out. That's the watermelon seed effect. How it works with aligners is that when you make an aligner for a teeth, you can have a shape molding effect going on where the aligner will try to compress the tooth from all directions. This is easy to make. So the net vector addition of all these forces causes a force to go straight through the center of resistance of the tooth. By the way, this is one unique thing of aligners that is really different from braces. That is, aligners can apply intrusive force literally through the three-dimensional center of resistance of a tooth, as opposed to braces, which find it really tough to do that because the braces only come on the surface of a tooth. So you can apply on the buccal surface or the lingual braces or the lingual surface. Never it has been possible to apply a force literally through the middle of a tooth. So that's where aligners have a huge advantage over braces. So all power to them. So this is the primary approach of fixing deep bites. The second approach, which I think is more propagated by the companies, is using the bite ramps. Bite ramps are literally like placing plastic indentation, no, like composite blobs on the lingual surface of teeth so that the bite is open. And then the posterior teeth are free to extrude. So this is the other approach of fixing it. I think this contributes very little to the opening of the bite, because once you have disoccluded the dentation, you still need to pull down the posterior teeth. And I think it's very tough to extrude teeth with aligners, because the aligner is gripping onto the teeth to have retention, and at the same time you want to pull it down. Physics principles are basically violated when you try to do it. I'll give you an example. When your car is not working, what do, right? I mean, assuming that everything else is fine, just the engine is not starting due to whatever, you get out of the car and you push it, right? So what you do, you get out of the car. You don't try to push the car by sitting inside the car. Intuitively, that won't work because it will violate Newton's third law if it worked. So the same happens with extrusion of aligners. You cannot pull a tooth down when you're trying to grip onto it to get retention. So that's why bite ramps have a limited ability to extrude teeth. So here's an example of a patient of treated by deep bite, and generally with aligner cases, there's nothing much to show because it's all invisible, right? So anyway, aligner treatment was done and the deep bite was fixed, and it was basically fixed by using the watermelon seed effect and less by the bite ramps. Anyway, just an example here. For the record, deep bites are not a great set of malocclusion to treat with aligners. What is a good malocclusion to treat are open bites. Now, if any of you have been skimming through the literature, you might have noticed that treatment of mild to moderate open bites is gaining a lot of popularity with aligners. Now, the basic mechanics of how open bites are treated are still the same for deep bites. They use both attachments and the watermelon seed effect. However, here the watermelon seed effect or the squeezing action is utilized on the posterior teeth. So the posterior teeth are squeezed. And again, because you can get a force right through the center of resistance, it works great. At least they do not allow the teeth to extrude at all. So the posterior teeth are very well controlled with aligners in terms of possibly intruding them. And on the front teeth, well, you can try a lot of things. You can try bite ramps, you can try to extrude them. But as we have noted before, it's tough to push a car while you're sitting inside the car. So just keep that in mind. You have to come up with certain auxiliaries, something to extrude these teeth. So just by the aligners, it won't work. So these are the two ways by which aligner companies have said that the open bites can be solved. However, our research has shown something different is at play, and which is primarily contributing to the open bite treatment, and that is the drawbridge effect. The drawbridge effect is basically like, the London Bridge, where the bridges are raised for ships to pass by. So that's from where the drawbridge effect name comes. That is, the rollback of an object creates extrusion of it, superficial. So as an example, here you see, so green is the pre and blue is the post. So as the tooth is rolled back, you see an extrusion. This is not pure extrusion. It is called relative extrusion. This is the primary mechanism by which open bites can be closed. The other way of closing open bite is by something called as a slight auto-rotation of the jaw. That is, when you get a slight intrusive force on the posterior teeth, the effect on the front is magnified. So like a 1 millimeter intrusion of the molar can lead to anywhere between 2 to 4 millimeter correction of the overbite. So that is the, on the left is the drawbridge effect, and on the right is basically liver principle in action. So longer the liver arm, the greater would be the correction. So the molar can be considered as the pivot and the incisor as the other end of the liver. So the more you intrude the molars, the more magnified will be the effect on the overbite. And how do we know this? Well, we recently did a research that got published last year, I think, where I was involved in very intricately with this research. And we went pretty nerdy with it to figure out what is causing open bites to close. What we did here is that we got 40 open bite patients that were treated with aligners. And we critically evaluated the records to see how teeth are moving. And we went did some crazy math in it, not recommended, but we went overboard. But the result was great because we could nail down how open bites are being fixed. So to give you a quick summary, overall, on an average, about 3 to 4 millimeters of overbite closure was being done. And as you can see in this slide, the primary mechanism by which it was happening was, of course, by upper incisor, lower incisor extrusion, and molar intrusion. The thing to catch here is by extrusion, what we meant was the majority, 37.9% on the bottom left of your screen, was having by relative extrusion, AKA the drawbridge effect, okay? Another 19% of the lower relative extrusion, again, by the drawbridge effect. If you combine the drawbridge effect, you're getting almost 60% of the correction, all right? The rest of it, majority of it, close to 30%, is by auto rotation of the jaw or by molar intrusion. So 60% drawbridge effect, 30% by some molar intrusion, 90% correction is happening by these two mechanisms. So if somebody is out there and trying to extrude their teeth or the patient's teeth by giving attachments and stuff, don't do it. You don't need it. Research after research now is sort of highlighting to it. So just keep this in mind when you're trying to treat open bite patients. Go for the molars intrusion if you can, and then look for the drawbridge effect. Now, if there are spaces, then you can use the drawbridge effect. But how about this? There's one of our patients here where there is no spaces, right? So uh, you have to create spaces. Now, you can extract, yes, you can, but be careful when you extract in patients you're treating with aligners. Just be careful, and we'll come to that, why be careful with extractions. So the moment you get a patient like this, you got to center down upon IPR because you need the spaces and you need the drawbridge effect to fix them. So this is what we did in this patient. We had a lot of intrusion going on in the molars, which who knows worked or not. But I think primarily we did IPR and we rolled back the teeth and the open bite was closed. Retention is a totally different story. I don't want to get into retention of open bites, but just be prepared to lose 50% of your open bite of the overbite that you see here in relapse. Just be mentally prepared because that does happen. Okay. So now moving to space closure. Now, how is space closure solved by aligners? Now, again, this is what is proposed by all these aligner companies or the aligner gurus out there. So the fundamental basis for any tooth movement is that when you apply a force on the crown of a tooth, you get a dumping of the tooth or a moment of force that causes that dumping. If you want to control tooth movement, you have to either get rid of this dumping moment or counteract it by an opposing moment. With braces, it is pretty easy to do, right? Because the wires lock in the brackets and this generates a couple, which creates this red moment on the left side of your screen. And you control the movement of the teeth, either knowingly or unknowingly, but it does happen. With aligners, you have to consciously apply this moment. And how is that applied? Usually in the form of those attachments, it is done. However, I think if you read carefully through your clean checks that comes to these companies, a lot of shape molding effect is also going on. So anyways, the bottom line is that you have to apply, or the aligner company has to apply these kind of attachments or these couple forces to create this red moment. So whenever you're treatment planning space closure, just clarify with the company or see on your clean check that how are they creating this counter moment. And you can move these attachments around to increase it or decrease it. Basically, you want to have maximal separation between these two attachments in the vertical plane. The more you get separation between these two attachments, the more the more moment you can create. So again, here's an example. It's a cartoon, I know, but this is how here the root is being controlled by applying these equal and opposite forces, and you get a root uprighting a moment on the canine. Another way of applying, the second way of applying this is by using power ridges. Now, power ridges can either be ordered through these companies. You can ask them to put power ridges, or there are special pliers that come to apply these power ridges. Now, power ridges are basically strong indents that you create by compressing the plastic with a plier or any sharp instrument. Once it creates an indent, it will push down on the tooth, as shown on this picture. It is basically used for incisor torque or root movement. As you can see here, equal and opposite forces can be created on opposite surfaces, and you can start generating the same couple or moment to control it. So anytime you see these attachments and power ridges, always think about the stress, that these are applying very high stress at these regions. And as I said before, I'm going to come back to it to tell you what can be the possible ramifications of these stresses. So here's just an example to show space closure. Say I've got a patient, a lot of anterior spaces, and space was closed. The space was closed for sure, but a lot of lateral open bite is happening. Now, this is not my patient, but I had similar patients that showed this kind of lateral open bite happening after space closure, and literally an edge-to-edge bite. Now, you can prevent it, but I think there'll be a pretty high chance you will get it at some stage or the other. The reason for that is, and this is a slide that I have stolen from Align Tech. I was close enough to get some interesting material on it. And this is one of the ways by which they show how they are closing space. So they say that you have aligners, you'll apply Newton's law here, equal and opposite forces will be created by an aligner gradually, and the spaces will close. What they fail to highlight here is that whenever aligners are applying this force, basic biomechanics tells you that, of course, first of all, forces would be equal and opposite. So the amount of anterior retraction force will be same as posterior protraction force. There's no way to prevent it, as opposed with braces where you can do a lot of stuff to prevent it. Also, what you're going to get, which has a more detrimental effect, I would say, are these moments. Now, these moments are not equal and opposite because they're dependent on the location of center of resistance. The further higher the center of resistance, more would be the moments. But you see, this moments will cause the posterior teeth to tip forward, which is not desirable. However, the front is desirable. So this posterior tip forward ends up causing your aligners to bow up, as it would cause even a wire to bow up, right? So this bowing of the aligner as the space is being closed is primarily responsible for creating this lateral open bite that is visible. So you got to be just aware of this thing, and that this is bound to happen, and you need to throw in stuff or circumvent this possible phase in some way, so that this doesn't show up. By the way, if this does show up, it is a very tough thing to fix. You have to go for refinements after refinements to fix it. And again, I'm not leaving you hanging in there. I'll get into it as to how get out of these situations if you have one. Okay, so with this, I think we basically covered like deep bites, open bites, space closure, like the basic broad movements of teeth. Now, once you know that aligners are doing all these movements, you go ahead and you start treating with aligners, okay? And once you are treated a lot of patients, you want to know that how good are your aligners performing. So what I'll do in the next few slides is that I will show you, it's like a summary, a critical summary or a critical review of what others, that is hundreds of other practitioners who have documented their results, have experienced while moving teeth in these manners. Okay. So we'll look at tipping, we'll look at translation, we'll look at rotation, we'll look at space closure as to if you're trying to implement these things with aligners, what are you ordering? And then what are you receiving? Okay. So just imagine that, and again, as I said, this is a distillation of all the stuff that is available from the literature that I'm putting out here. Now, tipping is the most common type of tooth movement that we do, which is great. So imagine that you are doing a aligner treatment and you plan for X millimeter of tipping. Okay? And if you planned X millimeter of tipping and you did the whole treatment, how much did you get through the set of aligners you ordered? The literature shows that whatever you plan, you will get 54% only out of that. Now, mind you, you have to compare it with something. With braces, you get almost 100%, right? If you want to tip a tooth, it does tip. There's no like, yes, I applied a chain on wires and braces. Oh, my tooth only tipped instead of 4 millimeters, which I thought it would tip, it tipped only 2 millimeters. No, it doesn't happen that way. If you have the space, you'll get full 4 millimeters of tipping. With aligners, that's not the case. When you plan out a movement in a certain set of trays, you don't get all of it. With tipping, you get 54% only. All right, what about if you're trying to derotate a tooth? So if you planned certain amount of movement, if the rotation is less than 15 degrees, let's say it's a mild rotation, you will still achieve 43% of correction. However, if the rotation is more severe, that is greater than 15, 20, 25, 30, your efficiency of correction just drops down. Literature shows it's about 23%. There's a lot of variation in this, but this is the average. So you lose a lot of correction if you have more severe rotations to fix. How about vertical movement? So let's say intrusion. Now, for intrusion, again, if you're planning X millimeter of intrusion, you will get only about 35% out of it. And the bottom figure is in severe patients where you get basically barely 20%. So you got to be cognizant. One thing that I want to point out here is that these are our planned tooth movements. So it doesn't reflect, like, people are building overcorrection also. So just treat this data with that factor in mind, that whatever you're planning may also incorporate overcorrection. So it's not necessary that you will end up with a bad treatment. It's just that it will be still underperforming. How about posterior extrusion, which says right there at the bottom right corner of this screen? People have yet to observe a desirable posterior extrusion of teeth. So it's very tough to extrude posterior teeth with aligners. Actually, the data on this is really very interesting. And the bottom two references, if you want to go into, you can get the hardcore data on it. It's almost like they were trying intrusion in 189 patients, and barely 41 got more than 1 to 1.5 millimeter, and only 2 or 3 patients got more than 2 millimeters of pure intrusion. So the data is pretty dismissal. And same with the extrusion. I think the figures are like 13 out of 64 patients got greater than 1 millimeter extrusion, and 0 patients got more than 1 millimeter. So be careful with these vertical movements. Okay, how about root movements, or translation for that matter? If you are planning that, if you're an extraction patient or you plan to do torquing, how much of the planning that you did really translated into clinical output? You can take a guess. It has not yet been observed. We have not yet observed on a consistent basis. I'm not talking about isolated patients here or there, but on a consistent basis, successful space translation, space closure, or the even tougher root correction or root movement. And why do I say that? Of course, personal experience, and I'll show one of them later, and also of the literature that has been reported. So far, it has been very difficult to conduct a study on this because ethically it becomes tough to conduct a full-fledged space closure study with aligners. Fortunately, there have been now 3 researches that have been conducted that have literally trickled over the years, like one by one. They have come over the past 5 years. So the research is slow. But the first one that came out was from University of Washington, done by the Greg Huang group. It came out a while ago. And what they did here was they had like 24 patients getting all 4 premolars extracted, right? And they said, all right, we are going to start closing space with aligners. And they went ahead and started closing with aligners. Literally, I think through the treatment, more than 50% of the patients had to be moved out of the study and switched to braces. They're not even gone halfway through or something like that of space closure. And many of the patients had to be switched from different protocols of aligners because the movement was not happening. So when everything was all said and done, only one patient out of the 24 subjects completed space closure. Just one patient completed. The rest went to fixed braces. And that one patient that finished just space closure, mind you, with aligners, had a pan that looked like this. This is the actual pan from the study. And you can clearly see the enormous amount of tipping galore that has happened with space closure. So needless to say, this patient was also switched to braces immediately when they saw the pan, and as stated in the paper yourself. And all kudos to these authors who were pretty honest to spell this out, because we don't see a lot of honesty in terms of showing what was the true outcome of your treatment in the literature. So this was the first paper that came out, and subsequently others got interested, and this was followed by another paper that I believe was in the Angle Orthodontist that came out, and they had kind of similar protocol. They had 30 patients and underwent extraction. Now, of course, the data is not good here for this kind of presentation. So what I've done is that I've taken out the data and created a little cartoon to show what they were trying to do. So this was a prospective study. So you can see that they were planning something for the anchorage control, and they were planning something for the incisor retraction. And on the bottom, I'll try to show what they finally achieved. So let's look at their planning for the molar movement. Now, their goal was to preserve anchorage. So they said to themselves, in the ClinCheck, we are going to create a 2.94 degrees. That's the data stated by them, about 3 degrees of distal tip. But we know reality is that we are going to lose some anchorage. So we are going to assume that we are going to lose about 1 millimeter of anchorage. That is what they thought for the molar. What did they actually achieve after that planning when the treatment was done? Well, they did get anchor loss, but they actually got a lot of it. Instead of getting a 2.94 degrees distal tip, they got the same amount of tip forward movement of the molar. And overall, at the end of the day, they got about 3 millimeters of the crown coming forward. And if you can calculate, that would mean about almost a millimeter and millimeter of the half the root coming forward. So it was tip forward of the molar instead of tip back as they had planned. Now, how about the incisors? Well, the incisors, they were confident and said, we are going to get pretty good movement of the incisor. We'll go for a little bit of translation with minimal tipping. So just 9 degrees of tipping and a lot of crown movement, more than 6 millimeters of crown movement. of course, they had to go for 6 millimeters of crown movement if you assume that you're going to get barely a millimeter of anchor loss. So pretty ambitious according to me, but nonetheless, how much did they actually achieve? Well, um, what they got was a perfect uncontrolled tipping. They don't say that in the paper, but you can take the numbers and calculate for yourself. Okay, it's pretty easy to do. And these are numbers that they stated. They got 4 millimeters of crown movement back, but they got almost 15 degrees of tipping. And they have stated in the paper that the root moved in the opposite direction by about a millimeter. And that is why, if you put all these numbers together, you come to the conclusion that instead of getting control tipping to translation, they ended up getting a big uncontrolled tipping. So very interesting to see, as it kind of beautifully backed up the paper by the Greg Huang group. And there was nothing different here that we could say that they were really different from the other paper that was published. And I'm trying to drill this fact home because this is where we are getting maximum side effects when we try to go for space closure, big space closures, that too. So just be careful. And I think recently there was a paper that came out in the KJ, I mean, not recently now, again, a few years back, but recent in the spectrum of the few papers that have come up, where they went further and they said that they just quickly measured the discrepancy. By discrepancy, I mean what they planned and what they achieved. So for the crown, you can see the discrepancy is not that crazy. They pretty much achieved what they wanted to. But again, when they went for the root, there's a lot of discrepancy of about 2 to 3 millimeters on an average that of planned and achieved. And this is not a small number because they never plan to move the root anyway more than 2 to 3 millimeters. So if you plan to move 2 to 3 millimeters and you get the same discrepancy, it's not wonderful news. Okay, that clearly tells you. Actually, they have stated in the conclusion better than what I can say here. And if you guys can read it on the screen, that would be great. Crowns, but not roots, can be moved to designated positions using clear aligners, primarily because such appliances cause tooth movement only by tilting motion. Okay, so this is their conclusion. So the third paper, it's like a third consecutive paper saying the same fact. So if I put all the literature together, without without even putting my experience into it, this is my conclusion as far as the movement goes, that tipping is the only feasible movement. It's very tough to say that about braces, right? But for aligners, the evidence is just overwhelmingly clear that tipping is the only feasible movement that you're getting. Okay, so when that is the only tipping movement, there's a good news behind it. There's a lot more research to be done. So any of the new innovators out there who want to do something new, there you go. You have so many other movements that you can create. Go ahead and try to do it. There's a lot of scope. That's the good news. The bad news, of course, I need not elaborate on the bad news because it shows that we are constrained, okay, by our latest innovations, aligners. We are constrained in a huge way. However, what all of us can do is improvise, right? Try to work around it. Try to see how we can still incorporate this in our practice and be just smart at making our decisions around aligners. We can only do that if we try to dive deep into it and understand why aligners are not able to move teeth as efficiently as braces. Okay. And I would say that a first principles based understanding really goes a long way. And we experienced that with the open bite study that I showed you. We had no clue there was such a big drawbridge effect going on for open bite correction, or the posterior intrusion, although mild, was playing a huge role. We just found out that by going to the first principles of trigonometry and math and applying it to orthodontics, and it gave us beautiful insight of how to treat open bites. So similarly, let's apply this here to understand why only tilting motions. Why not any root movement? Why not any kind of translation? So, as I said before, the fundamental basis of tooth movement is an interplay of this dumping moment and then the counter moment that you're putting. This creates the myriad types of tooth movement that you see. Now, braces and aligners approach it in different ways. Uh, Braces create this moment by using a wire in a bracket, and you can increase the size of the wire, apply torque, apply V-bends to create this moments. You don't have the same luxury with Invisalign or with any other kind of aligners that you're using. Um, so this is the basic constraint. And this constraint is very obvious because when you go about measuring what a wire and a bracket can deliver in terms of force and moment, you will see how greatly aligners underperform. Okay. With braces, you have the ability to quickly switch wires, increase the size of the wires, play around a lot of your equipment. With aligners, you're stuck, right? You have this aligner, that's it. It's made out of a plastic that is not decided by you, but decided by the manufacturer. And you got to do what you can do with it. So that's the number one constraint. So let's look at how much we are underperforming in terms of force delivery with aligners. Okay, so let's standardize comparison. Let's say that we are trying to push that canine back into the arch with wires. We know it's a child's play. You put in a wire, and that single wire, be it a NiTi, be it a beta titanium, be it even some kind of stainless steel, multi-stranded for that matter, is going to eventually push it in, just one wire. And if you want to do the same with aligners, well, how many aligners do you need? Maybe like 15, 20, 25, 30, 10? I don't know. You need multiple aligners to get there. So why are we going through so many aligners? Okay, why do we have to do that? Well, this graph will tell you and give you the answer. So forget the red and the black line. Just treat it as one consistent line. So this graph is measuring stress spread across over a period of time. For easy understanding, just replace stress in your head with force. If that makes you, just if you feel easier to grasp it that way. So just replace stress with force. So you start with a certain amount of force on the left side of the graph. So just say it's a very high force, right? And now you follow the minutes on the bottom graph, just from 20 to 40 to 60. By the time you go to 100 minutes, one aligner loses 90%, close to 90%, or 80% of its force delivery capacity. And this is very, very interesting. And why this is interesting? Because if you plotted the graph of a wire on this graph, so for example, if you plotted the graph of a steel on a NiTi wire, it would be straight, right? They don't lose anything over 60 minutes, 80 minutes, 100 minutes, or 120 minutes. In fact, they don't lose anything, especially in NiTi, even over 30 days. They constantly apply a force. However, an aligner drastically loses force. This graph, if you can remember this graph, this is a good graph to remember, is known as a stress relaxation graph. And why I'm emphasizing it's a good graph to remember, if a sales rep or a guru of some company comes to sell you aligners, just ask for this graph. Like, how good is your stress relaxation graph? The gentler the slope, automatically better the aligner. Easy does it. And every company has a stress relaxation graph. If you dig deeper, they will provide you that. They have to provide it. And if some company does not have it, they're basically weak on R&D. So they, they need to do it better. So they have it, stress relaxation, creep, and other things, but stress relaxation is the key, okay? And this is what good studies are analyzing on a continuous basis to figure out what aligners are doing. Here, there's another study where besides measuring force, they've also measured moment or the torque, that we want to create with aligners. And they did it on all the three planes of space. So anyway, that is not important. What's important to see, you see how the green and red lines are dropping down to 0. So every peak is a new aligner. So you can count the number of aligners that were given, 1, 2, 3, 4, 5, 6. So every peak is an aligner. And you see every peak immediately goes down to 0 very quickly. And that's the drop in the force. That's the stress relaxation that the aligners are exhibiting. So this is another research. Of course, I cannot show all the researchers, but two very good researchers that show that the drop is quite quite catastrophic. And one interesting conclusion they had was that they said that data clearly demonstrated that each aligner, although creates very high force, this is then followed by an exponential decrease in the forces or the moments it is creating. So good luck creating any kind of root torque or root control that you want to do um, with these kinds of aligners. Because remember one thing, that if you want to create some kind of root control, on an average, you need about 2000 gram millimeter of torque, okay? And if you need 2000 gram millimeter of torque, which is pretty high because you need root control, the force that you need to create on these two attachments or buttons you are placing would be approximately 200 grams, right? Assuming that 10 millimeters is the distance between the two forces. So 200 times 10, 2000, right? So 2000 is a lot of force for aligners to do because they're losing force very fast. So maybe one way of seeing, what if we create more force to begin with? Okay, so we create more force, we might lose then relatively less force at the end of the day. So this has been played around with too. So what if we build more activations to our aligners? That is, every aligner is supposed to do more movement so that the initial force is high. So there was a study that was done, and which did 0.5 millimeter activation, which is more than the standard of 0.25 or 0.3 millimeter, but they did 0.5, 1. They also had a 0.75. I'm not included it here, but basically to show low activation 0.5 and high activation 1 millimeter. And you need not go deep into the graphs. Just in general, if you look at the 0.5 millimeters activation, the force levels are like, somewhere between 2 and 3. And when you go to that 1 millimeter activation, you see overall the force has dropped in between 1 to 2 newtons by and large. If you just visually compare it, you see that with more activation, force actually is going down for one particular tray, which is not good news at all, right? That means more activations are not working to increase the force. So more activation, less force. What actually works if you want to increase the force is if you order for thicker aligners, then you get a greater force. So maybe a smart idea can be that when you approach some root torquing moments or space closure, thicker aligners might be better. As of now, as much as I know, at least with Invisalign and 3M and other companies, they're not playing a lot with the thickness of the aligners. They don't offer different thickness aligners according to the stage of treatment you are in. But the research indicates that if you want more force, more moment, maybe thickness can play a role. And this is just one of the factors that can play a role. Now, there's one important caveat to understand, that if you apply more force initially, here's a research that shows what happens. So the top two graphs are done with thicker aligners, the F22 aligner and the Ercolock Pro aligner, which is like a more of a scientific name for a particular aligner brand, aligner material. So thicker the aligners, you see how the force is dropping even much more quicker with these aligners than the ones with thinner aligners. However, you do start with more force, but the drop is pretty hard. The thinner aligners give you a more consistent force. So I would say that you can read this graph into saying that if somebody wants more of tipping movements, go with the thinner aligners. If you want torque or moment, the research indicates thicker aligners might be better. And of course, keep the activations low. This is a study whose link is right here because I didn't include it in the notes below. If you want to read this study, you can. All the studies, these studies are tough to read. The Bain material is limited. That what you want to know more describes the research. Anyway, so based on all these principles of applying moment and torque, that you can go for thicker aligners and keep the activation low. um, we have consciously tried to incorporate all these findings in our patients. Here, this is one of my patients that I was treating at UConn. And this was an older gentleman, and he wanted specifically aligners. He had a history of treatment when he was a teenager, and due to social implications, didn't want to go for braces, which is understandable. So we said, okay, you know what? We are going to go ahead and treat you with aligners. The goal was to align the teeth without running into a negative overjet, because there's so much crowding on the lower that we could easily flare these teeth forward. So the wiggle room was very, very small for us. And he also insisted, because of food impaction and stuff, on the upper left posterior side, and the pen, you can see the upper left has a slight space. He wanted that space to be closed if possible. So even said, okay, we'll give it a shot and go ahead. So I started treating the patient, had a bunch of attachments. I think I probably went around like 3 or 4 times with Invisalign to build in all sorts of modifications. I think I ordered about 90 to 95 trays, as many trays as possible, uh, uh, small activations, and started treating the patient. Anyways, won't go into a lot of details into what I did with Invisalign, but here is the treatment. So kept on moving the teeth, did a bunch of IPR, tried to flare the upper teeth, did more IPR on the bottom, of course, because you don't want to run into a negative overjet. Was a very, very tough movement. And as you can see, started to also close the gap. And the way we were closing the gap is um, try to use some auxiliaries for additional torque and all that. I won't go into the details of that, but basically what our treatment plan was to apply a lot of torque to the molars by systematically keeping the force application as wide as possible. So if I was applying a force here on this crown, the other force was in the gingival portion to keep maximum distance between the two to get a decent root torque. And ordered many, many trays so that we keep on fixing the root. So anyways, kept on doing it. And then finally, at this stage, after about a year of treatment, we thought, okay, we are going to enter a refinement stage because we are in an edge-to-edge bite and we have closed the space. So let us check how we are doing. And surprise, or I don't know, surprise, look at the upper left posterior molar. We didn't get any root movement at all, I think. Although consciously we were thinking we were applying a lot of torque and trying to make it as efficient as possible. Of course, molars are not a good candidate anytime for root torque, but regardless, it just didn't work out. So there was a lot of tipping. We made the patient aware of it, that there's a lot of tipping, and without braces, the chances of fixing that are pretty low. And well, the patient accepted the fact. We went through our refinement, we fixed whatever else we could fix, and eventually let go of the patient, and the patient making the patient aware of the fact that you have a tipped molar right there. So there can be periodontal implications down the line. And the general dentist, the hygienists were made aware of that too. So it kind of beautifully aligned with the literature, unfortunately, about the root effects. So now we understand why, at some level, what's going on, with the aligners and why they're not able to create that kind of torque because of all those force dropping and the stress relaxation that happens. So to go on one layer below, why does an aligner experience so much of stress relaxation? Like, why does the force drop so down? And the answer to this is actually lies in the modulus of elasticity. Uh, for those who have kind of lost touch with this, I know we kind of went over this in our orthodontic residency programs. Modulus of elasticity is basically trying to measure the energy an appliance can transmit somewhere else. Like you can almost say the stored potential energy it can absorb and then transmit it to move teeth, to move stuff, in general. That's modulus of elasticity for you. So in our terms, it combines force and activation together. Okay. That means you can get force application, a lot of activation, and so a lot of movement. That's modulus of elasticity. So at the end of the day, higher the modulus of elasticity, more are the chances that the stuff can move things around more efficiently. Okay. So let's compare. Okay. These are all the materials at the bottom row that we use in orthodontics: stainless steel, beta titanium, nitires, and now clear aligners for moving teeth. So on this graph, where does stainless steel land? Well, it's the Mount Everest, right? It's the peak. It almost touches 300 gigapascals. That's the unit for stress. It's a lot of stress and force it can apply, and a lot of activation will give you a lot of force. So great method for delivering a lot of energy. Beta titanium is a radical drop to about 70 to 80 gigapascals. So it's way smaller. How about austenitic or martensitic nitide? They are pretty low too, around the 50s. And the martensitic nitide is about, I think, about 30 GPa. And again, values can vary depending on which research you're going to. And I don't know if you guys can imagine and that how much would be clear aligners on this graph. Uh, well, I had to force myself to draw something because it was ridiculously low. It's almost close to zero on a GPa scale, gigapascals. So you have to enter the world of megapascals, which is a smaller unit, and it gets very, very low. And if you guys are interested in saying that maybe some other company works better, maybe my company is better in terms of delivering modulus of elasticity, you're more than welcome to read this article, which analyzes not just one, two, three, but three, four, I think there were even more different polymers that make up aligners. And you would see that they are ridiculously low. As you can see, they're in single digits right here, 2, 2.5, 3. So the modulus of elasticity is super bad. A relative comparison on our famous stress strain graph. So these are the big graphs of steel, beta titanium, and nitide. And where is the clear aligners here? Well, if you can see the red dot at the bottom left of the screen, right there, that's where aligners are. So it is very low, as I said, about 1 to 2 GPa. So that's the root cause. Your aligners are not equipped to deliver that much energy to start moving teeth in radical manners. Okay. So this is like, if you want to call it, what's the first principle reason? This is the first principle reason that you got to deal with. So how does all this thing, and by the way, this is like 40 times smaller than a martensit nitide, which is supposed to be the most flexible wire in our profession, which nobody wants to use for translation, right? Nobody wants to use a nitide for root correction. And still our nitide is 40 times better than the best clear aligner on the market. So you're dealing with a stuff that is so much inferior. So ambitious tooth movement should be, I would say at best avoided, or I don't know, do something else about them. So this is how it translates when you apply all this at the clinical level, right? So for example, this is one of your patients and you want to just align the teeth, right? And you want to go from the left image to the right image. Now let's assume that you are planning 10 trays on it, or whatever these are. Let's count 1, 2, 3, 4, 5, 6, 7, 8, 9 trays, okay, on it. And every tray will do a certain movement, right? So one tray will do this whole orange or yellow span of movement, okay? And the next will do certain next. And by the time you hit the last tray, the teeth are beautifully aligned. Now, after learning all that we have learned, that how aligners underperform, how much force loss is there, and blah, 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 you can easily say that whatever I've planned, I'm barely going to get maybe 50% or 60%, being very optimistic of it. And I'll lose 30% of the planned correction, okay? So every tray will lose 30, 30, 30, 30, 30% or 40%, whatever it might be. On top of it, if you have not achieved what you wanted to achieve with tray 1, it is carried as a baggage to the next tray. So actually, this is still underestimation. You would underachieve even more here on the next ray and the next ray and the next ray. And gradually you hit a point where you say, uh-oh, I need to go for refinements. And so having 2 or 3 sets of refinements is not uncommon. And it adds more money. It consumes more chair time. It adds a lot of dissatisfaction. And then you start contemplating of switching to braces. So this is the blueprint of refinements and as to why it happens based on the literature and first principles. So this was one of my patients whose clean check I've shown. And this is exactly what happened, that we had so many errors that 10 trays were insufficient. And aligner companies do that again and again. Whenever I'm treatment planning with Invisalign, they would be very conservative in giving me aligners. Like they try to do these movements in 10 trays or 12 trays. And if I do that, I'm sure I always end up going for refinements. So I hate that because then I have to scan again, put the attachments again, take the old attachments off and go through that cycle, which is pretty annoying. So so this is all what can go wrong with aligners, okay, that we reviewed so far. And this is the question we started with. So a quick recap of that would be that all these aligner material, doesn't matter which company you're using, is giving you, first of all, very low force, okay? It's better to do less activation because they are equipped to only carry out less activation. They have low flexibility. In fact, using the term flexibility is a disservice. There's hardly any flexibility. It can deform pretty quick. There's a rapid force decay, no matter from what force level you start, unless you are very force level when it kind of stays. And overall, there's less transfer of energy, unlike stainless steel or brackets, where there's almost 80 to 90% transfer of energy at the macro level, at least. So all these features tell you something about these materials. These materials are not rigid like steel. They're not flexible like night ties. They are not elastic like rubber bands. What are these? All aligners are basically viscoelastic material. And any of you go ahead and Google this up, right? Viscoelastic material. Viscoelastic materials are good for what? They are good at absorbing shocks, right? So they are dampeners. You put force and they'll dampen the force. They're good at dissipating any energy you supply to it in the form of heat. They don't transfer that energy as kinetic energy for movement of teeth. Okay, so just be aware. Metals are the opposite. They will transfer the energy that you are supplying in the form of kinetic energy and move teeth. Or your rubber bands, they will supply that elastic and they will go almost 1:3, 1:2, depending on how you use them. So all viscoelastic materials are actually good for, they are good for opposite of what we are trying. They are very good for retainers because even if inadvertently you apply some activation on your retainers, these retainers will act as force dampeners. So your tooth won't relapse more than a certain amount. Okay. And this is what historically they were used for. When it started from Kessling and went to Naums and others, they were using it as aligners of a very minor movement so that you do the movement and then you retain it. So it's very important to set this as your basis and then launch yourself for some kind of active treatment. You got to realize, you got to be humble and realize the limitations of aligners, and then try to do some movement with them. So to sum it up, treatment with aligners, what did we learn? As I said, it's a limited time, and I wanted to make it as comprehensive as possible. Of course, at UConn, we do kind of a separate / course type sessions on this, and we dive very deep into individual mechanics. But here, what we learned is what I can give you as a clinician. Maybe it will be useful to you, maybe not. But whatever I'm going to state in the next 2 slides have been hugely useful for me. Okay, immense benefit so far. Number one, use more trays. I would implore, if it's not coming at a big cost to you, it does not come to me at a big cost when I order these trays. Use as many trays as possible. I'm now almost down to using 2 trays per week. There was one patient, I did 1 tray per week. Sorry, I went up to about 5 or 6 trays. What I meant to say was 1 tray per day. So try to use as many trays. There was one patient in whom I used 1 tray per day. So it was literally like that guy was changing contacts in the morning for his eyes. He used to also change his trays for his mouth. So he used to do that. And the reason for that is that I am ordering less activation per tray from the aligner companies. I'm telling them, please don't move teeth a lot per tray. Can you make it less? So less movements would mean I would automatically need more trays, which works because if I build in more activation per tray, the force just goes to zero even faster and the force is even lower. So, and I pile up more errors as I go along. So lot of trays, less activation. Okay. So for me, baseline, every movement, every treatment is going like 80 trays, 90 trays. Okay. What has this done to me is that I'm not doing a lot of refinements. Okay. Very, very less refinements now, hardly any. I did one like about 3 months back, literally. So that has worked great for me. And between thinner and thicker material, if you're planning a lot of milder to tipping kind of movements, thinner is great, which most of the aligner companies give you. If you have the ability to switch to a different company who applies a thicker material, I don't know if you want to do that way or if your aligner company is open to adjustment, but thicker material would be better for the heavier movements like torquing or translation. So I'm not able to do this because Invisalign does not give that option. These days, I've started looking at 3M now to see if I can use them, but have not tried it yet. Also, this is super important. The last point on this, whenever you're trying to solve a malocclusion with aligner, think how you can solve it by just tipping the teeth. You can go for root control aspirationally, but don't please build a lot of it into your treatment. If you're treating with a crossbite, think if you can fix it just by tipping. If you're trying space closure, see if it is possible to just tip the teeth. If it is possible, do that. Crowding, rotation, everything. Tipping is the most predictable movement that you can build into aligners. So here is one patient of mine that I actually think recently finished, and she was came as a for retreatment to me. She had been in braces for 3 or 4 years, and I had not treated her. I don't know if this had relapsed or this was left that way. Very less I could ascertain from her history, but she had this specific bite problem. She said, and she said her jaw shifted and all that stuff. The caveat to it was that she was moving out of the country and wanted treatment to be done very quickly. I said it's a better idea to go wherever you're going and start the treatment. She insisted still if something can be done now, because it will take a lot of while for her to get adjusted in the new place and yada, yada, yada. So I said, okay, we'll do the treatment. She didn't want braces. Of course, if you have been 5 years in braces, you don't want that. So I was like, okay, you're going to be like a trial patient for me, but we'll go ahead and do it. Hopefully I'll improve it. If not, totally fix it. So we had like 6 months to do it. Right off the bat, I thought I'll order a lot of trays. If you look at the center photo, I just wanted to roll those right posterior teeth out, like keep the center of rotation at the root apex if possible, and then tip them out. That was my whole objective to do it. And then wherever we are, that's it. So ordered, asked her to do 4 to 5 trays per week. At some point, we even went to 6 trays per week. That required a lot of trays. So about 95 trays, that gave us about 5 months of treatment. And I said, please, 22 hours per day, you're just taking them out for brushing and eating. She was highly compliant, which is, by the way, a huge thing. You need compliant patients for this to work. So went ahead, did the treatment, nothing magical here. I hardly used any buttons, literally just the shape molding effect. She didn't want any treatment, by the way, for the lower. She was happy with the way it is. We didn't touch anything, just treated the upper. And this is the patient. I mean, I just saw her actually a few weeks back for these pictures, and I was decently happy. Yes, do I want to settle them? Yeah, I want to settle them. But over the years, I've just, I started accepting this some kind of disocclusion of the posterior teeth. It just comes with aligners. I mean, you get lucky with those brachycephalic patients where you don't get this kind of disocclusion, but then you get it for these kind of patients. So you can see, I don't mean to show this as a patient that worked great, so every patient will work great, but this is something that I consciously did with no refinements, just a lot of trays and just building tipping movements and just eliminating all kind of translation they were trying to do for me, like root torque and all that stuff. Okay, so just one more tip before I wind off. Research has shown is that you want your patients to not take their aligners on and off quite frequently. The more patients take their aligners on and off through the day, the lesser force they create. So you can see on the graph on the right side, the more times they are taking their aligners on and off. So you see 10 times, 20 times, 30 times in a day or two or a week. I don't know what the data is for, but more times you take it on and off, more is the drop in the force. Okay. So just, it's just little tips here or there, the more the patients can, maybe warm beverages, any drinks, just you can have it on with the aligners, who cares? Only for severe eating that you need to take them off. So this was the last tip that I had from my side. I always have this graph in my mind, the Dunning-Kruger effect given by a famous Nobel laureate, on how your experience with anything would work. And this has truly worked me for aligners. When I started with aligners, after treating a few patients, I was at the peak of this graph in my level of confidence. I was like, whoa, these things are great. They work so seamlessly. And I would make all my 80%, 90% of my practice aligners. And then as you gain more knowledge and experience, you hit a slump where you see that you actually don't know much about it. And there's so much more to learn. And I experienced this graph through my residency, through my practice, and now with aligners, that every time, like in my second year of residency, I was so confident with everything. And some of my teachers from my school, I don't know if they remember, but I was like super confident with everything. And then later when I came to UConn, I learned that I didn't know much. And then I had to go up this graph slowly. So still learning, still trying to do as best as I can. The one thing that I've learned, not because I love biomechanics, but I think this is the truth, is biomechanics is the law, and everything else that you hear around yourself is just recommendation. Okay. Hear it, forget it, doesn't matter. Okay. Stick with the basic science principles and you'll be a very happy orthodontist out there. I try to imbibe this to my residents here through all my courses. I'm not here to tell them what to think. That's their life, their choice. They can think what they want about appliances, techniques, and whatever. I just hope through my teachings, they can learn the art of how to think. Okay. If they can just develop this technique, what is the right way of thinking, piece of orthodontics, I'd be more than happy. It was wonderful sharing all this information with you. So thank you. And I'll be happy to answer any questions.
Thank you, Dr. Madhur. It's been a wonderful presentation, and we had almost 450 participants listening to your lecture. That shows how much they valued the lecture. And the best part is when you started your presentation, we had this 450, and still we had the same number. And that shows how much people got engrossed in your lecture, how much they learned. And on behalf of Indian Orthodontic Society, I so much appreciate your wonderful presentation, especially when we are plagued during this time of like the do-it-yourself aligners and all those things, which is getting, I'm sure it's happening also in the US, I guess. So during that while, this particular presentation was so enlightening, it's like so much that the crux of your presentation really conveys this message that the orthodontist is the best clinician and the specialist to offer orthodontic treatment with aligners. Way to go, doctor. And we so much enjoyed your lecture. And Dr. Ritu Dugal, ma'am, please.
Yeah. Thank you so much, Dr. Kannan.
Yes,
so it
ma'am.
was wonderful, Dr. Madhur. After listening to you, you are the true master, and you actually prove that the iOS who is conducting the master classes. So today was absolute a master class. You are a real guru. You made the thing so simple for all of us. And it is after listening to you for an hour, it is rightly believed that these strong foundations can withstand any kind of storms. And this in spite that there are exponential development in the technologies and the orthodontic material, and there is a new age system with us. The fundamentals of biomechanics is the key to success in any professional, that is the being an orthodontist. Hence, it is the utmost importance to understand and apply these biomechanic principles to get a successful and efficient treatment outcome by for any patient and by any orthodontist. So, thank you very much for a wonderful presentation, and you explained the things so beautifully in animation form that learning biomechanics actually was so simple, and to correlate how it was different for aligners. I think no textbook have clearly taught us that how we are using it in aligner system. So most of us who are just the beginners, by listening to 1 or 2 days courses or lectures, and we think that we can practice this technique, you have made them understand that it is not so simple. Knowledge, again, your first slide, if I remind them, everybody gains knowledge. Once you start connecting those dots, that means the how you practice, implying your knowledge makes you feel that how successful that technique would be. So thank you very much for enlightening all of us. We have few questions in the question answer box. If you permit me, I'll take one by one. And everybody was very, very thankful to iOS for organizing this event, because this was a unique kind of an event for them. So the first question in the chat box is, does the watermelon seed effect occur due to stress accumulated distortion of a liner, leading to rather than an uncontrolled tipping as opposed to true intrusion?
Um, Thank you,
Do
Dr.
you want me to repeat? Do you want me to
No,
repeat the question? Yeah.
no,
Okay.
no, I heard it fine. Thank you. Thank you for the question. Thank you for the feedback regarding the lecture. So coming to the question, so yeah, watermelon seed effect, you're right in pointing out that it is something that is stress induced. Everything is stress induced. So basically the aligner is squeezing down on the teeth. So it's creating a lot of stress. Now, I would say that braces have more chances of leading to uncontrolled tipping because the force is never close to the center of resistance, assuming you're applying an intrusive force at the bracket. But that's one big advantage of aligners. It's a good way of creating that mild intrusion where the force actually goes through the center of resistance. So, I mean, by going through the center of resistance, I don't literally mean right through the dot. That will, again, who knows, we don't know where the center of resistance is for every tooth, but you have a much better chance of hitting the center of resistance with aligners as opposed to braces. It comes with a caution, not for a radical intrusion, because you'll hit a roadblock pretty soon with intrusion. Yeah.
So thank you. The second question in the chat box is, aligner technique says treatment with aligners is 50% faster than braces. How true is the statement?
I'm sorry, where is that quote from?
No, there is a question that the aligner technique says treatment with aligners is 50% faster than braces. How true is that statement?
Well, of course, the treatment is absolutely false. Unfortunately, we would love it to be the other way. But with aligners, it is actually, I mean, and there are credible reports on this. It's not just my feeling or whatever, but why that biasness is coming in, why these statements circulate, because we inherently pick very straightforward patients for treating with aligners. So when we do that, we end up on a timeline, just treating them in 6 months, 8 months, or maybe a year. So we come out with the feeling that, whoa, that was quick with aligners, but try treating a severe crowding with aligners, or try treating a huge open bite with aligners, and you'll have to bail out of the treatment eventually. So yeah, the statement is totally incorrect. And if you start with the same kind of malocclusions, you will end up with more time, way more time, actually.
Thank you. Next question is that if tipping is the movement really possible, why not select cases for aligners where treatment is possible with removable appliances? Also, why not plan the treatment based on removable appliances tooth movement only? That may work right. So probably the doctor who wants to know this is trying to say that all the removable appliance cases can be treated well with aligners, or they are the right choice of aligners for them.
Yeah, in the removable category, I would say aligners is the best, by far the best appliance possible, if you are considering the universe of removable appliances. And why is that? Because stuff like Holly or whatever you might have as a removable appliance, which has just a wire going in the front, it has only one point of contact with one particular tooth, right? Um, However, aligners can apply on the whole surface of the tooth. Remember the shape molding effect? So you have much more control as opposed to any other removable appliance. So aligners is beautiful way if you want to stick to removable appliances for treating teeth.
Another question is that, are you recommending aligner companies to produce different thickness aligners at different stages of treatment to produce efficient tooth movement?
So yes, I would say though, and unfortunately, so here's the thing, how it goes. As opposed to other sciences, what is happening in orthodontics is, and it has happened, I've seen this again and again, and my teachers would know it better than me perhaps, that when self-ligating came in, the same history happened. When implants came in, the same happened. What happens is the industry first brings forward an appliance or a device, and then we educators, clinicians slash researchers start investigating it. However, in the other companies like the pharma company or some other company, first the research happens in the labs and then they come out with a product. So the products are already pretty pure and good to begin with, and they have to just kind of, fill out some little cracks here or there. But you know how it happened with self-ligating brackets, when they came out, everybody said faster treatment, more arch expansion, frictionless mechanics, yada, yada, yada. And later we got to know they're no better than regular braces. Like you can do with self-ligating or with braces. In fact, the literature now shows that self-ligating brackets underperform at certain levels, especially in controlling root movements and all that stuff. So same is happening with Invisalign, where yes, we would love to recommend, I would love to say that, if we can get some variable modulus aligners, which, various variable modulus orthodontics, so variable modulus aligners, that as you are approaching space closure, switch to thick, or it has been already pre-packaged for you based on their estimation. So you move to thicker. But I think from a cost perspective, this would not work out for aligner companies, because now they have to have a stock of different materials. That adds a whole layer of complexity to their manufacturing process. If there is some smart innovator out there who can somehow very smartly do this, well, yeah, go for it. Definitely a good tagline to sell your stuff to begin with.
Another question is that what happens to the root of posterior teeth that lies in the maxillary sinus when an excess of intrusive force is given?
Well, yeah, I mean, so that's just a general question for intrusion, that if you see a tooth in the sinus, then you got to be definitely careful. If you have an open bite patient and you are like, okay, I'll use TADs or something to intrude, you got to be just careful. Aligners won't have that much of an effect if they're already sitting there, because at best you try, you won't be able to intrude more than 0.91 millimeter at best. So with aligners, you're you're not that much concerned. I would say, yes, the concern is huge if you're trying tabs and you're trying to intrude them. So be careful. Yeah.
One more question, that how much amount of force is applied to begin with during all four premolar extraction case and aligner treatment?
Well, the force, so the aligners have changed the game of measuring force, right? So what happens with aligners is that you can still start with, say, 200 grams of force or whatever. There'll be two problems. Number one, how will an aligner company tell you how much force they're applying? I don't think even they have a clue how much they're applying, because they're literally like how you do on a cast. You move a tooth and then you make a liner over it and you just give it to the patient, So they are doing the same thing. They're making these little stages of treatment and you're just putting the aligners on. It's only when we bring them to the lab and we measure the tension by using Instron machines or other stuff that we get to know, oh, okay, we're getting that much force. So that's one thing that you won't be able to know. The second is it will vary a lot. Suppose an aligner is just touching a button, then you have to measure the stress force by area, as opposed to a aligner touching the whole surface or some part of the surface. So the actual meaning of stress calculation gains more importance. And if you dive into this research, I didn't talk a lot about megapascals because suddenly then I'll lose you there in the discussion. But it's actually all these companies or all these papers measure every time aligners with stress, because force will be such a vague way of quantifying this. So as clinicians, that variable is tough for us to control. We can indirectly control it by applying. I know for a fact Invisalign has very thin trays, so it tries to apply a lighter force. If you want to further modulate your force, go for small activations. So for example, if a company gave you 30 trays to treat some malocclusion, I do that all the time. I literally write in the comments to them, can you triple the number of trays? Thank you. So they then send me 90 trays with no cost to me, because I've signed up for a plan which doesn't transfer the cost to me. So in this way, I'm able to reduce the force. And I didn't include that paper, but just be aware, there are one or two good papers on the extreme side effects. It was published by the chairman of UIC, Sat Allah Reddy. He's UIC chairman now. He published on the adverse effects of aligners. So when you have a lot of force by aligners, there are some TMJ, some sinusitis, some kind of ramifications, and well documented now. So everything points towards more trays as per me. So that's one way to reduce the force effects.
So pertaining to this only, that if we use more trays per week with less activations, won't it be that the force is increased as the force is inversely proportional to activation?
Yes. So if you consider this as an isolated scenario where you're just comparing force and activation. So if you activate an aligner, say by 1 millimeter and the other by 0.25 millimeters, the 1 millimeter over a 3 to 4 day to 5 day observation period on an average will deliver less force. But a 0.25 and 0.3 millimeter activation on a 5 day average will be either comparable or maybe slightly more than that. Okay, so that's a fact. However, that's what we are trying to mitigate. So a bigger factor that increases the force is, at least the initial, impetus of force, is when you give in a lot of activation. So when you give a lot of activation, you get a very high force, but there's a sudden drop. So when you measure over a 4 day period, there's pretty low force, but that sudden spike is crazy. So you want to level that out as much as you can. So you want to say, and of course it causes a lot of inconvenience to your patient. For like half a day, they are in terrible pain or they don't like it at all. So what you want to do is you want to say that let's have very small activations, and that will automatically mean many more trays, and the patient has to change more frequently so that your treatment time is still the same. You're not going like, okay, 5 years of treatment. No, you're still like 1 year of treatment. Here you go, a lot of trays. And what I do is that I check with my patients, how was it? When did you feel comfortable? When did you feel the tightness go away? And you'll get a lot of information by asking these questions. Because I don't know which aligner company, the choice of material, those are variables. So just talk to your patients for their comfort level also.
Thank you, Dr. Madhur. And there is, in your presentation, you mentioned that the shape molding effect should be utilized more rather than putting attachments over the teeth. So a question pertaining to that is that if by these attachments, if the force or the stresses, the amount of stresses are increased, but if we do not, but we do need these attachments for producing a couple force and control tooth movements. Then in your practice, what do you recommend? How do you achieve this control tooth movement without these attachments?
So I don't know if a white screen is visible right now or not. If it is, great. If
Yes,
not,
yes, it
okay.
is.
So I will see if I have the ability to change the, okay, so yeah. So if suppose this is a tooth, okay, and sorry, very bad sketch, but will work for now. So you have a button here and here, and you apply a force, great. So that is going to produce the couple, and you can literally be very specific with the aligner company, say, I want the attachment here or there or wherever you want, and you can control the net moment it's going to produce. In this case, it will be like that. Now, as I said, you can increase the distance to increase the moment. You can decrease the distance to decrease the moment and do funny things with that. The other way is you can say, and this will depend your back and forth with the aligner company, which they can, is say that I want to apply this force on this whole surface area here, okay? And instead of a button, I have this whole surface area here. Can you apply a force for me? Okay. And they can do that by, creating such kind of systems. And then you get the same couple out of it. Now, the advantage of this is that the stress is low. So if the stress is low, remember that graph where I plotted stress and time? So if you start with a high stress, the drop is more. If you start with a low stress, again, this is exaggerated graph. I don't mean it will be so straight, but the point is the drop in force would be lower. So you'll get more juice out of every tray. But again, it has to be carefully balanced that the stress is not so low that is not creating the moment. Okay, so there's a balance, but it's better to still go with the shape molding effect if possible and apply that. If you are stuck with the button, say if you are stuck with a button, same thing, go for very small activations. So keep your activations very small. So decrease your activations and go for more trays. That's the way to deal with buttons, which I'm also stuck with. So sometimes the company just refuses due to their technological limitations that they cannot do that, they cannot do this. So then I'm go with buttons and just be careful about if you can increase the size of the button. I don't know aesthetically how it look will that's another way of mitigating it. But yeah, I hope you got the point there. So.
And what is your take if the attachments are present on the palatal side rather than on the labial side in terms of stress?
That's a good question. And I've experienced that myself, that Invisalign is particularly diffident about, putting attachments on the palatal side. They don't naturally come up with that solution. Although I've done them myself, I've applied power ridges and attachments, and it is fine. It just depends on how you're creating your force system. So for incisor torque, I think either a power ridge or some attachment, either or, is required on the palatal side. Aligners usually just give me power ridges for the lingual side. But I think it should be as effective if your patients don't mind it, feeling a lot of buttons or attachments on the lingual side. If they are okay with it, it's all okay.
And now we want to know, is there any protocol for extraction cases to avoid bowing effect? What protocol you are following to prevent the bowing effect?
It's a very good question. Very good question. And So there's one thing to just understand the biomechanics, the basic principle of which will maybe indirectly answer the question is, unlike wires and brackets where we know where the force is being applied, so we can boil down a system into one couple, two couple force systems, and then research wise and clinically both, we can improvise on those systems. With aligners, there are so many multiple points of contact of the aligner with the tooth surface that it becomes very tough to know when, where, what kind of stress is being applied specifically. So coming to the question, recommendation regarding space closure. First, avoid space closures, and that to extraction-based space closures as much as you can avoid them. Try to convince your patient to go for fixed braces for sure. Some people try to do a little bit of aligners and then braces, or first braces and then aligners. Fine, you want to do that, but don't go for the full thing. If you are going for it, if you are doing that, go for cases which have a lot of crowding. Okay, so a lot of crowding, you take the first premolar out and then you're looking just to roll the teeth into those extraction spaces. You know how you see sometimes a forwardly tipped canine, which is causing the crowding? When you take a premolar out, you just need to roll back the canine. That is doable because what you did, you boiled down your extraction case to a simple tipping movement. Okay, so it's based on the movement. If you think it will need translation, avoid. Because right now we don't have the technology, or the companies or whoever has not come up with the right way of yet. I mean, yeah, you can say, oh, I'll put buttons and I'll cause torquing, but it won't play out because the material, remember, is inherently deficient to apply such high amount of torque. So unfortunately, that won't play out. I myself have not attempted a lot of space closure. I have done maybe a couple, but they were just required easy tipping into the extraction space. So it kind of worked out at the end of the day, but the finishing was not fun. When you get that Boeing effect, you reach the realm where now you have to create extrusion. And as I showed in the presentation, and as it is out there in the literature, extrusion is the most difficult tooth movement with aligners. Over 160 patients had been done in a trial where they got 0 millimeter extrusion in more than 80% of the patients. So you got to be extra careful. It doesn't mean it does not happen. It's tough.
Dr. Madhur, according to you, it is basically the mechanism which is working in aligners is only tipping. So we just want to know that how does the arch expansion occurs, or if the arch is in the development stages. So is there any change which aligners can bring in the transverse plane? Can we expand the arches with aligners? Hello. Am I audible?
Yes,
Yes,
madam.
ma'am, you are audible.
Yeah, sorry. Dr. Madhur, just
Yeah, I hear you
can we
now.
expand the arches with
Sure.
aligners?
Let me bring up the screen again. So yeah, so expansion is possible. So transverse, if you're looking at, say, two teeth, say the molars or the premolars, yes, your aligners will apply a transverse force because you can order periodically expanded aligners through the 30, 40 trays and it will align. It will expand. Now, the movement that you should expect with aligners is, now I'm looking at this from the front. So when you take your frontal picture, so imagine this molar is in one corner and there's another molar in the other corner, okay? So you're applying this expanding force right here. Be mentally prepared that you're not moving the root, okay? No matter what the aligner company promises you, okay? It is very interesting somebody asked this question because I received a thesis from University of Melbourne where they did a CBCT-based studies with aligners over 45 patients where they had expanded them, okay? And the thesis came to me where they said that we did that and we got good expansion. My comment to that then was, did you quantify what kind of movement did you get? So they sent me a bunch of root values and crown values. When I put those values together, you basically got uncontrolled tipping to some patients experiencing controlled tipping. When they had purposefully gone in and tried to do the best expansion they could, that is move the roots and expand it nicely. And the reason is still the same. The aligners won't create appreciable root torque. So you should expect a movement. So for example, if this straight line is the tooth, you should expect a movement like that at best. Most likely you will going to get something different though. You might get something like here, like that. That means the center of rotation is here. So the root will go a little bit in the other direction and the crown will go this way. Now, if you have a CBCT, if you have it, and if you have taken it and you can read it, just make sure that the root is within the cancellous bone, like right in the middle, so that you have the wiggle room to tip it out. If the root is already close to the buccal cortical plate, as in a skeletally constricted arch, be careful, because the root won't come forward, or the cortical plate is going to provide a lot of restriction. So just remember, you're going to get uncontrolled tipping, maximum to controlled tipping. If that is okay, go ahead and do it.
Have you experienced or have you used aligners in adult cleft patients on a pre-surgical mode?
So far, no, I haven't done any. Yeah, we haven't done any cleft patients here with aligners. But one thing is for sure, what I've heard is you get great cooperation, so they will work in whichever ways you're using. The patients are very compliant, at least out here. But I haven't, personally, I haven't, if you're asking me.
And have you experienced any effect on the thickness of the aligners on TMJ?
That's a very good question. I think there's been some good research on it, but because there's a lot of business, what you can say, dilution of evidence by big businesses that's going on in the market. So be aware, be careful. So there have been reported TMJs, but when these patients, especially these direct to consumer services and other companies make you sign up a treatment plan, many of them have a clause that you are restricted from reporting stuff without the prior knowledge of the company. So especially companies here like ClearCorrect, like Candid Co. and other companies here, they make you sign that. And this is like, those comments are hidden between the bunch of documents that you sign blindly for most of the things. So those comments are all taken off, even if they come, and no way the patients can go and file a lawsuit. So what's out there is limited evidence. And I would recommend that Sat Alareddy article, which I have in one of my other presentations, to read about the adverse effects. But the data is not still very obvious because the data is not coming through. It is being blocked by these huge corporates. But I would be really amazed if we don't see TMJs, not in every patient, but in few of the patients, because you're literally putting lots of splints between the teeth and you're moving teeth in various directions. And the killer of it is none of the companies have no clue where the center of resistance is, because we orthodontists have not found out yet where the center of resistance for every tooth is. There's no research. Any of you residents, if you're hearing this, go and do this. Go to the literature and say, I want to find where is the center of resistance of two premolars. You will get a Dr. Nanda or a Upadhyay or a Burstone commenting on it that I think it is close to the premolars, but there's no evidence. It's just their feeling where it is. So when you don't know the center of resistance, you don't know what is the moment of force you're putting, right? Because it's force times the distance to center of resistance. If you don't know the moment of force, what are you counteracting? So aligners at best are randomly moving teeth without full knowledge of how they're moving. And if they're randomly moving teeth, they're bound to cause sometimes some side effects. And those side effects will show up in various areas, including the TMJ. So it's no surprise. It won't be a surprise if there is a big lawsuit sometime down the line relating this to that. But I'm also confident that the companies would just absorb it. Nothing was going to happen. So Yeah, I'm sorry, I'm digressing here a bit, but if those of you have watched that movie, I don't know, Thank You for Smoking. It's a old movie, 2007 or 6, I forget the exact year, but if you can watch Thank You for Smoking, it's about how the smoking business literally suppresses all the research on cancer, lung cancer, and the acute ramifications. Like there's a huge lobbying. And I think this is for the first time we're encountering with now Invisalign, because it's a big company. There's a lot of lobbying out here to suppress the side effects. So something to be aware of.
Is there any research which is going on regarding the viscoelasticity or the other materials to solve the problem of stress relaxation or forced decay?
That's again a very good question. These are very nice probing questions. Uh, so people have some ideas. They're trying to use some kind of filler substance to kind of alter the property, and it is a very dynamic field. But the interesting thing is that before we see it straight happening in aligners, we'll see it happen in some other industry which uses the same thing. And we are already famous for copying and borrowing from others, be it the night or be it the beta tite, whatever, we just see happen in some other industry. And it just, so far, I don't think, as far as I know, they have come up with that material that is elastic and is like an aligner. So because that would be like, that would be the holy grail of aligners. And that would really bring aligners to the mainstream in a big way. If somebody cracks that if one aligner can be like an elastic substance, so literally, if you want to exaggerate it, imagine you have an aligner like a night high, right? If you had an aligner like a night high, there you go. One aligner takes you through like 20 trays. And then guys beware, then you'll have even more dental practitioners doing aligners. So there'll be heavy competition there.
So another question for you, that are power ridges is the type of attachment. What is the difference between power and an attachment?
So you can consider the attachment as that it's like a blob of composite that is put, right? And power ridges are like the negative of that. That means instead of creating a power ridge around which the aligner will mold and apply force, you can take an aligner, use a special sharp instrument to create a indentation in the aligner. So you can imagine an aligner having a curvature forcing on the tooth surface. So there's no foreign substance being added, but the aligner being compressed to create this small bubble or indentation in the aligner, which will press on the tooth. So that's, power ridges.
So one of us wants to know that what is the role of an orthodontist in aligner treatment, keeping in mind how many companies are directly approaching the patients and bypassing the orthodontist. So what is your view about it, Dr. Madhur?
There's a lot of business and philosophical view actually about it. So one thing is there, which I believe should apply globally, but definitely applies to America. I think to India too. I would be surprised if it does not. So what, see how, so here's the history. And again, my peers would be, or my seniors would be knowing better, but in the 2000, when Invisalign really started coming into the industry, when those two kids who were not orthodontists made this company, there was a big opposition from AAO. They didn't like it at all, aligners coming in. They were fearful, right? All of us were fearful that, oh, aligners are coming in and then everybody is going to do aligners, and poor us guys who have trained ourselves so many years with braces and wires and bends and loops, and suddenly we lose our bread and butter. So, but what the aligners did was that they didn't really take away the market of the orthodontists, but they opened this whole new market where those patients who never went to an orthodontist, because just they were so conscious about getting braces, they started reaching out to get treatment. And when those guys started reaching out, it just opened up this adult market. And if you plot the graph of adult market in orthodontics, it has grown huge. Even in India, I believe it has grown a great deal. I mean, of course, there are other factors, social and others, that have contributed. But the aligners is a good way of satisfying that demand. Now, what it does is that when it pulls those peoples in, there is a spillover. Some of those people are not satisfied and they go to braces, okay? And the braces means they eventually figure it out and then go to an orthodontist, right? Also, a person who has got treated with aligners, when it comes to the question of their kids, there's a pretty high chance that they go to an orthodontist because they dig deeper into it. There's a pretty high chance. So you're just getting this continuous influx of new patients. I think the same is going to happen with direct to consumer aligners because they are no way close in delivering the kind of treatment. Because I'll tell you, there's one research that came out. I forget. Sorry, guys, I forget where exactly. Where they just tested a simple thing, and one of the residents can do this research in India too. So what you do is that instead of you taking the impression, you ask your patient to take their own impression with the putty based, okay? And then you also take an impression and then pour models and see the difference between the impressions between the two. Just quantify that. So that research quantified it. And the impression taken by the patients were far, far inferior than by a specialist. In America, even the dental assistants sometimes are not able to take good impressions for aligners. So imagine all these direct-to-home aligner companies who send you this little putty impression and they ask the consumer, they call them consumers, to take their own impression. So they are off the rail on the first thing itself. You need to make that go very nicely. And then, of course, there are no buttons that you can put. There are so many other things you cannot do. So they will never be anywhere close. They will open up a separate market for those people who don't have the resources or means to get a full treatment. They will go to them. They will get the treatment done by them. But this thing will create a huge awareness about braces, about getting the right people. And eventually people will find out who is the best person. They'll Google who is the best person to get treatment. And out comes the name of an orthodontist. So it's all good. It's all an add-on for us in the long term.
Can a progressive step down be used for open bite treatment by adjusting the thickness and freeway of the aligners?
I'm sorry, can you just repeat that again?
Can progressive step down be used for open bite treatment by adjusting the thickness and freeway of the aligners?
I don't know if I'm getting
Probably the question is that they want to know that can we close the open bite progressively by adjusting the thickness and the freeway between the aligners?
Yeah. Yeah, I mean, these are some of the ways that modified approaches have been tried, but the whole thing comes down to you have to pull that tooth down, right? So you have to grip on that tooth first and then apply an extrusive force on it. And that's the problem that I said, that when you're sitting in a car, intuitively to somebody who doesn't understand it, will feel like, yeah, why can't I push the car when I'm sitting in the car? I should be able to push it. But it is not possible. Same thing if you try to apply that. If you're gripping onto something, even if you clear off some material, it's very tough to apply a counter force that's going to pull it down at the same time. Unless you move out of the system, say, for example, you create this space and then you make a little hole in the aligner, put a button, and ask the patient to do a rubber band from that aligner to some attachment on the bottom teeth. Now, yes, you can move it down, but you cannot move it down by staying in the same system that you're trying to move it down. Okay, so that's where it becomes a problem. Now, somebody might say, I can take leverage from the front teeth. Yes, you can, but then there's another problem with aligners, they will slip. So if they are pulling down on the tooth, that means they're slipping off the tooth, they won't be able to grip on it. So there's a very tricky situation there. So extrusion is tough, very tough.
Somebody wants to ask that, what about compliance indicator? Can you elaborate on that?
Yeah, so I think the compliance indicator is like a little chip that at least the Invisalign asks us every time we are checking out, and would they like to have that placed, because it basically measures by various ways of measuring it. Oral temperature is the easiest way of doing it. So as long as the patient is wearing it, you have the 37 degrees Celsius or close to that temperature. And so when you have that temperature, you can say, oh, patient is wearing it. And when the temperature goes down, that means the aligners are off and the patient is not wearing it. it's a good indicator, but I think most of the times your patients are pretty honest about it, because most of these aligner patients hopefully are self-motivated. So if they're wearing it, they're very upfront from it. There are some ways of finding it out. If you probe the patients more and more, they usually tell you that how much they're wearing. If you ask again and again, how much did you wear it? The second is, as we do with headgears, if some of you are doing headgears, I've done them long time ago, but the way a patient takes out their aligners and wears it, that's number one indicator. So they'll easily take it out and wear it. That's like they're doing it constantly. The other is, you might see some, like, some wear and tear in some way of the aligner. So if that is there, that means they're wearing it. And if the aligner is ripe clean when it comes off from a patient's mouth, just assume that that's not happening. You don't even have to see. But I think, again, having a chip, if your company is giving that, is great, to just have it on your phone, that how much your patient is wearing it. It's a good way to know.
There are many case reports which have come and recently, which states that the use of microimplants in extraction cases. So what is your take on it, Dr. Madhur?
As in mean like microimplants with aligners?
Yeah.
Okay. Yeah, I mean, yeah, it's very interesting history. I mean, I am moving away from microimplants big time, because they're very limited application as per me, and you can do many things without them. But with aligners, so the microimplants basically serve the situation, the purpose of securing anchorage. Other than that, the tooth movement that you're supposed to do has to still go ahead with your normal aligners. Implants cannot really influence movement of the teeth as much. So they will secure your molar, but or whatever anchorage you're trying to preserve, but the movement has to be still, so it has still the same limitations as a regular aligner treatment is happening. So yeah, it would be the same. I don't know if there is any specific situation where you want to use it, then I can dive deeper, but the implant doesn't change things a lot.
Thank you very much. It was a wonderful evening with you, Dr. Madhur.
Very honest from bottom of his heart. Really, thank you, Madhur, for coming out very openly. Really, thanks a lot. It will be our pleasure. Hello, if you can accept the certificate from iOS, please do.
Thank you. Yeah, appreciate it. Thank you so much.
Over to you, madam.
Sri Krishna sir, may I request you to present a certificate of appreciation to Dr. Ritu also? Yeah, Kannan is back.
Yes, ma'am.
I'll just share the certificate for Dr. Ritu, if you can place on record our appreciation. It is Dr. Surya there? I think Dr. Surya is not there. So, President-elect sir, if you could do the
Yes,
honor.
ma'am. I'm there. I'm just waiting for Vice President Dr. Surya. Ma'am, thank you for being patient and being there throughout and putting the questions to Dr. Madhur. Thank you, ma'am.
My pleasure. My pleasure. Thank you for inviting me. Thank you.
Thank you, ma'am.
Thank you.
Yeah. So that was a wonderful evening, and we started at 7 o'clock. It's 9:15 in India. And Dr. Madhur, really, we appreciate your patience, especially the time which you took to answer all the questions. And that was, again, I have to tell you that it was a fantastic presentation. And thanks to Dr. Ritu, ma'am, you moderated so beautifully. And this was a wonderful evening as such. You both of you made this evening so memorable. And yes, so Dr. Madhur.
Thank you, iOS, for giving me that opportunity. Thank you.
So, the President-elect, and the Secretary, ma'am, please, we have to host Dr. Madhur in India for one of the IOCs. So, in future, please make it a point. It's a request personally from my end to bring him to India, and we'll show the Indian style of hospitality, and we'll take the knowledge from him. Okay.
You know, we were not able to cover all the questions. There are so many more questions that are posed. It's such an intriguing topic. It is new, and we could see that the audience had so many questions to ask of Dr. Madhur. Dr. Ritu did the best she could, but I think we need him physically here to answer.
Yeah, I know, ma'am. It was exactly 36 questions. I had a count of all the 36 questions, and Dr. Madhur actually answered at least 22 questions. So I just went for a glass of water, and that was the time. Okay, we thought we did truncate on this point. So I think, Dr. Madhur, we had to learn a lot from you. So please keep yourself free for India sometime. So you have to come down here and share your knowledge with us.
I must add that you have ignited a spark in the audience, that they all came with so much of questions. And I think the number of questions that they're still getting them. And if you have to answer all them, you'll have to stay for another few more hours.
And we still have 250 participants still listening, and something they're just eagerly waiting for a little more tip from Dr. Madhur, something which they don't want to spill it, miss it right. It's fantastic. So thank you all participants.
Can we share the feedback form?
Yeah. The chat box again, dear participants, I shared the feedback form again in the chat box. Please, it is very important that we know it's your criticism, let it be positive, let it be negative, but we need to have your feedback that really helps us to evolve with our masterclass programs for future. So please make it a point to fill up your Google Forms, the feedback forms. Okay?
Also to get your certificates.
Yes.
Can I speak for a second, Dr. Sridevi?
Yes, of course, sir. Keluskar, sir, is it?
Thank you. Yeah.
Yes, that's why I specifically pull you up here in order for you to say a few words.
Madhur,
Yes,
thanks a lot. Very nice. Nicely and simply fine explanation of the aligners. It was really nice. And especially the modulus of elasticity point which you got up was a relevant one. And I like your quotes, learn to think, and the other one, the curve. We know as the age advances, we know how less we know, and then we start learning again. Great things. Thank you, Madhur, for sparing your time and being with us on Sunday morning in US. Thanks a lot.
Thank you, Dr. Kaluskar, for being here. Appreciate it.
Thank you. Thank you, Dr. Sridevi. Thank you, Dr. Shilju.
Kannan, some requests from members saying that they have not received the feedback form. Can you just share it again, please, in the chat?
Yes, ma'am. So yes, I pasted it again on the chat box. It's like.
Thank you, Dr. Kannan. Let me just conclude by saying that the simplicity that was exhibited was amazing. I think the clarity of thought infused a lot of questions. And I think I must appreciate you for the amazing honesty and the highest level of modesty. I think your tips that you have given were brilliant on the clinical management of aligners, especially. And the kind of scientific evidences that you gave was really, really interesting. And that has really ignited people to go and research more on it. And most importantly, you have bust the myth of aligners as a magic potion for easy treatment. I think you need to do your work, the hard work, and get results the hard way. I need to conclude a brilliant lecture and also an eye-opener for all, not to fall for the gimmicks of the companies of aligners. Thank you, Dr. Madhur. It has been wonderful listening to you. Every time I listen to you, I think I become a fan of yours. I must admit. And thank you, Madam Ritu Madam, for wonderfully conducting moderating the session, and the questions that you so patiently took. We really appreciate you for that. And thank you, Madam Secretary, and Kannan for wonderfully moderating the whole session. I thank Dr. Keluskar sir for being here. I know Keluskar and Dr. Madhur have a great connect. I also saw Dr. Anup Baluri. They also have a great connect, and it's nice to see. Thank you, Mr. President-elect and Dr. Puneet Batra for connecting us to Dr. Madhur, and also all the distinguished EC members and all the attendees for coming here. And I think this is one of the most exciting, interesting, and absorbing lecture that we have seen in the masterclass series.
A lot of record numbers, I think, probably like an IPL, we have to see the attendance, questions, a lot of records made today.
And I think Dr. Madhur has become a superstar. He really was one. And I think we have to call him physically and interact with him on a personal basis in one of our conferences in the future, because you have to answer a lot of questions. Thank you so much. And with this, we conclude. Good night. Take care. Stay safe.
Night.